All right, everybody. So welcome back to the renal systems review here. We're going to get kind of hop right back in, specifically with a case regarding infection. So very general presentation. Patient presents with nausea, vomiting, flank pain, and fever following 3 days of UTI symptoms. Mike, what does this make you think of? Not trying to be too tricky here.
Nephritis, maybe?
Yeah, so the way I was taught to look at it is like if you have a UTI and you start seeing systemic involvement, that should kind of raise your suspicion for pyelonephritis. Systemic involvement meaning like fever and nausea, vomiting, like more systemic symptoms, not just localized to the urinary tract. So treatment for pyelonephritis in general, for the case of exams, ceftriaxone is the standard of care, IV ceftriaxone. If they're inpatient, they need to be admitted. And if you can treat it outpatient, which is fair, it can be done, ciprofloxacin is very, very commonly tested as the treatment because of its broad spectrum. It's also a good setup to test fluoroquinolone side effects. So complications of pyelonephritis, Mike, what do you think of? Yeah, definitely
Um,
be worried about sepsis. What about specifically in the kidney? Yeah, you kind of had to read my mind. So I'm thinking like perinephric or renal abscesses. These usually get tested a as like somebody with pyelonephritis treated appropriately with antibiotics, but the symptoms just aren't improving. Or they're like long lasting. You have more days of symptoms. You're not getting the improvement you'd expect. And the big thing to know about that, so like I mentioned here, how will it present? A persistent fever despite appropriate treatment. So you're throwing IV ceftriaxone at this person and they're just not getting better like you'd expect. This is a good setup for them to ask, like, what would your next step in management be? And if you thought there was an abscess anywhere, like usually goes, you know, throughout the systems, whether you think it's like an abscess related to like diverticulitis, whatever. What do you do if you kind of suspect an abscess in the belly? What kind of study are you reaching for, Mike?
CT scan.
Yeah, so and I don't have a question on that. That's just something to know. If you think there's an abscess in one of these organs, or if you think there's like a complication post-infection, so same kind of idea with like pancreatitis into walled off necrosis versus pseudocyst, you want to get a CT to get a better image of that. So let's say you do have a renal abscess. Um, what's your antibiotic treatment, and then when would you consider draining it? The drainage one, that's a tough one, like the specific size for it, but.
Is it 3 centimeters?
Wow, that's impressive. Yeah. So treatment, drain it if it's greater than 3 centimeters. From the research I did, a lot of times they recommend broadening out your spectrum and going really high powered for these abscesses. Because if you're treating it, with such it's got to be something with anaerobic coverage, which Zosyn or Piptazo has. You also want to have like it, depending on the type of patient, obviously, if there's contraindications to aminoglycosides, Gent probably wouldn't be on there. If they have risk factors for MRSA, especially like if you were to grow it in the urine culture, then Vanc would be indicated. So just keeping in mind that you need something with anaerobic coverage with an abscess. So usually you'd up that to Zosyn, I would say is probably your best answer for an exam. And so here's what I was getting at earlier. A special patient group that is always admitted with pyelonephritis, like if you see it on CT, like they have some enhancement and then you're thinking it's pyelo, or they have any hint of systemic involvement, like who's always getting admitted regardless.
Pregnant patients?
Absolutely. So pregnant patients are at higher risk for complications from this, both as far as like effects on birth, like premature labor, et cetera, as well as just um, more severe cases of sepsis if it were to progress to that. So here's actually kind of an odd case that kind of takes a little bit of pathophysiologic knowledge, very interesting one. So a 60-year-old man, newly diagnosed nephrotic syndrome, presents with right flank pain and hematuria. His vitals are normal. His exam is significant for right flank tenderness, but is otherwise normal. His UA shows many RBCs, but it's otherwise normal. His ultrasound shows a right kidney that is enlarged compared to the left side. So what kind of comes to your mind when we see this? So somebody with nephrotic syndrome now presenting with flank pain.
Is renal vein thrombosis?
Yeah, so kind of a textbook exam question here. Um, and going right into it, what's the pathophysiology behind it? Why does this occur, especially associated with nephrotic syndrome?
Yeah, so in this patient with nephrotic syndrome, you lose your antithrombin 3 because it's a protein, so you enter a prothrombotic state, which predisposes patients to obviously thrombosis. especially in the renal vein.
Very good. So, if they ever ask you, this is more of a step one question, but like your pathophysiology behind it being the increased loss of antithrombin 3, you're considered hypercoagulable. Not only can you present with renal vein thrombosis, but thromboses in other locations as well. It just seems to be that the most commonly tested one is the renal vein thrombosis. Um, so next step in management, if you're suspecting renal vein thrombosis, to kind of confirm that.
So next step would be a CT scan.
Yep, absolutely. Could do an MR angiography as well, but usually in most cases, a CT scan would be um, your next kind of step in management. And what about treatment then?
Treatment would typically just involve like anticoagulation. And
Yeah, absolutely. So they'll give you something telling you what the right anticoagulant would be. I doubt they have you choose between anticoagulants in this scenario. I did put a little note in there, a little bit of reading that I was doing. Thrombectomy is an option, so it's an important thing to know is just the anticoagulation. You want to break up that clot. So now kind of a related case, kind of a similar-ish presentation, but different risk factors for sure. So a 35-year-old male, history of IV drug use, fevers and chills for a couple weeks. You got a systolic murmur with the left lower sternal border, and now he's presenting with flank pain. So you get a CT, and you see this picture here on the exam. Um, what's your diagnosis, Mike?
is this renal cortical infarction from septic emboli?
Perfect. Yeah. So this does not necessarily only have to be in the kidney, but they love showing a kidney CT because it's really easy to depict that kind of wedge-shaped infarct. This picture kind of shows it, but it's a really big area of involvement. So if you see a little triangle of decreased enhancement there, that means there's a clot there. And that could be tested in a multitude of different ways, whether it's IV drug use with endocarditis and septic emboli, if they just had a cath or an aneurysm repair, that could represent cholesterol embolic disease. Um, really anything that could throw off little clots. They'll give you that nice wedge-shaped infarct. You could also see this in the spleen, would be very similar imaging with a wedge-shaped infarct. Those are usually the most common where you can really see it nice on a CT. So good things to keep in mind there. So, next one here, 31-year-old male, history of hypertension, presents with right flank pain and hematuria. He has bilateral masses palpated over his flanks, and his ultrasound shows bilateral cystic changes of the kidneys. So, basically, gave you all the answers that you need. What's your diagnosis here, Mike?
Is autosomal dominant polycystic kidney disease?
Yep, absolutely. So autosomal dominant, the way I think about AD and like adults, so you're more likely to see this in adult patients. You're likely going to have a family history, whether that is of kidney disease or sudden death. We'll go into that in a little bit, but good to know, especially just to be if you have bilateral involvement. Usually you're looking at a genetic issue, just in general. So ADPKD, very nice. What's our pathophysiology here? I'm not going to go into like too much of it here, but it's really the expansion of these cysts leads to the renal dysfunction. And since there's like increased like outgrowth of tissue, you're going to have localized ischemia, increased renin release. So you're going to have like a secondary hypertension due to this. If you were to have a ruptured cyst, one of these ruptured cysts, um, it can definitely present with hematuria. Obviously, you'd be leaking blood directly into the collecting system. So, not always will they present textbook with bilateral flank pain or masses, hypertension, and hematuria, but definitely be on the lookout for that. So diagnosis, we just mentioned it with an ultrasound. A renal ultrasound is often a good answer with the initial workup of kidney disease, unless you have a really good reason to already suspect, renal abscess, like we mentioned, or a vascular phenomenon like a renal vein thrombosis or an embolic phenomenon as well. So how do we treat ADPKD, Mike? Yeah, so really how do we get to transplant? There's really no cure yet. There's research being done in ways to kind of prolong the kidney survival. But just like with any other kidney disease process, what's considered renal protective is ACE inhibitors. Obviously, the physiology behind that, dilating the efferent arteriole and kind of relieving some of the afterload on the kidneys is kind of how I think of it. Can kind of boost that GFR and prevent like the problem with hyperfiltration and a lot of these different things. So by taking away the RAS pathway, you kind of are able to protect the kidneys at least to try to bridge into transplant, which would be definitive management for these patients. And then, a lot of times this is going to be a good way for them to set up renal transplant, and then they'll ask you a question about it. So just be on the lookout for that kind of connection. So, what about extra renal complications associated with ADPKD? There's definitely one that tends to be the most high yield, but there are some other ones as well we'll discuss.
So the high yield one I think you're thinking about is probably the associated with berry aneurysms in the brain that are higher risk of rupture. And then there are also a lot of extrarenal cysts, especially in the liver, that can be observed on imaging.
Very nice. Yeah. So, liver and pancreatic cysts, the berry aneurysm is very high yield. It's also, I didn't know this, but associated with nephrolithiasis or kidney stones. Um, whether I don't really know the pathophysiology behind that, but I would definitely know the berry aneurysms. This is why we ask these patients, if you have any suspicion of this, have you ever lost any family members suddenly? Like that would be more of a subarachnoid hemorrhage type picture. If you find an incidental, liver pancreatic cyst and both kidneys kind of starting to look a little lumpy, kind of like this picture over here, then you kind of start putting two and two together and start suspecting this is your kind of origin. Um, so yeah, that's a good one to know, definitely. ADPKD is one of those like genetic conditions that can lead to a lot of mortality. So it's important to realize. Usually it's pretty blatant the way they present it. So we're going to go into a few cases here, or a couple cases that are very high yield to contrast with each other. So just kind of keeping in mind who's the patient that's presenting to us, even though their presentation is going to be much the same. So a 75-year-old history of CAD and PAD presents with hypertension despite treatment with three antihypertensive medications, and he has an abdominal bruit. So what's our diagnosis here, Mike?
This is sounds like renal artery stenosis from like
Absolutely.
atherosclerosis.
Yeah, so whenever they give you, they give you coronary artery disease, they give you peripheral artery disease, and the question, maybe they have claudication when they walk, they're basically trying to build this schema in your mind that this person is a vasculopath. Like they have diffuse atherosclerosis everywhere. So it's not out of the realm of possibility that atherosclerosis would be happening in the renal arteries as well. So next best step, if you suspect this,
So the next best step would probably be imaging, just to confirm the diagnosis.
yeah, what would you go for?
Probably go for maybe a CT angio, but I think the test answer is ultrasound.
Bingo, you're right. Test answer is ultrasound. I was kind of trying to think through this on my own. And I was like, maybe they have, since, you're going to have decreased blood flow to the kidney already with the stenosis. Do you want to, give them some contrast? I don't know if that's necessarily the reason why. Both of them are appropriate. I would say the duplex ultrasound probably, like, ultimately is probably easier to get. Um, so maybe that's why. Um, but yeah, so you look for the duplex ultrasound, you look for the stenosis, the narrowing in both in the arteries there. So, what's our treatment for renal artery stenosis?
Usually it's still like ACE inhibitors. Usually stenting isn't really recommended, and
Yeah.
then just like peripheral artery disease management.
Yep, very good. So really it's going to be ACE inhibitors, notably unless there's a 30% drop in EGFR and increase in the creatinine by 0.5, where I've also learned like greater than 30% increase in creatinine as well. What's important is that you can expect with an ACE inhibitor, even in a normal, like not somebody with renal artery stenosis, that you're going to get a bump in the creatinine with an ACE inhibitor. Like that's definitely something that you should expect. But knowing 30% is a pretty good number to know. If you have 30% increase in creatinine or drop in your EGFR, that usually indicates that that's a little bit too much. And that would be your indication to like stop the ACE inhibitor and maybe do some more investigation. I do mention here, you can revascularize these specifically with stenting because usually these are proximal atherosclerotic lesions, atherosclerotic plaques that are very proximal in the renal artery. So if the imaging shows that it's favorable, you could possibly potentially do revascularization with stenting there. But usually on the test, your treatment is going to be ACE inhibitors, and just be ready to say like, oh, we need to hold the ACE inhibitor, stop the ACE inhibitor if there's over a 30% change in the creatinine or EGFR after that. So very good to know, very high yield case for renal artery stenosis there. Also can be bilateral. Those are usually the patients where you see the bigger bump in the creatinine. is if it is bilateral, because as you can imagine, if you have another kidney to kind of compensate after the ACE inhibitor, your creatinine won't increase as much. But if both are affected, you kind of see that more. So a 35-year-old woman, bruise in her neck, and she also has treatment-resistant hypertension, same as this other guy. So what's our diagnosis? What are you thinking now, Mike?
I'm thinking probably fibromuscular dysplasia.
Absolutely. So textbook case with the carotid bruit going on there. So fibromuscular dysplasia. Next best step there. What would you go for now?
I think this is ultrasound as well.
Yep, same thing. And we have that nice image over there um, from Radiopedia. You can see kind of that almost like similar to what we see like PSC, that string of beads type appearance where you can see all the way down the length of the artery. There's abnormal kind of contour. It's not smooth all the way down. So treatment for this, I'll kind of spoil it. Same exact thing. We're going to give an ACE inhibitor. There is a chance that you can do balloon angioplasty, notably without stenting, because like I mentioned, these abnormalities in these arteries are throughout the length of the vessel. So in contrast with the renal artery stenosis, where you're going to have like a proximal lesion most of the time, the entire artery is affected. So chances of placing consecutive stents, all one right after the other, is very low. So it'd be more of a balloon angioplasty type picture without the stent. So good to keep in mind. Very high yield to contrast them, mainly just the demographics. So you have an older guy with vascular pathology already versus a younger woman with treatment resistant hypertension are kind of the textbook presentations there. You got anything to add, Mike? Pretty textbook cases there.
Nope, that's kind of what I was thinking as well.
Sounds good. So moving on to stones. So specific case here, patient with known Crohn's disease presents with symptoms of kidney stone. So colicky flank pain, maybe radiating into the groin, maybe some gross hematuria. What kind of stone are you suspecting, Mike?
Usually, calcium oxalate.
Yeah, so I cannot emphasize the amount of how high yield the pathophysiology really is here. This relation is just very good to know. So basically, as we know with Crohn's disease, we can have more involvement, obviously, like ulcerative colitis only affecting the colon and very continuously. Crohn's it can affect anywhere from mouth to anus, skip lesions, specifically can cause like right lower quadrant pain with ileal involvement. So involvement of the terminal ileum then leads to malabsorption of fat in that region because the ileum does do a lot of our fat absorption. Because we cannot absorb fat, calcium binds fat. This is a principle that we see all the time. So, same kind of thing we see in like pancreatitis with the whole hypocalcemia due to saponification of fat. That like the same idea that calcium will bind fat instead of oxalate. So I'll kind of put this up as we go. So because calcium binds the fat and it's no longer binding the oxalate is able to be reabsorbed into the blood rather than being bound to calcium and then being excreted in the stool. So oxalate goes into the blood and it finds the free calcium in the blood and therefore will end up in the urine. So we're going to have a larger amount of calcium oxalate in the urine. So also high yield. What's the treatment for these stones specifically, especially in this Crohn's disease patient? Good. Yeah. So that's one part of it. The very, very high yield thing to know is that although these are calcium stones, you do not restrict calcium intake. In fact, you would want to increase it because the more calcium that you can put in the gut, the more oxalate will be bound up by it and therefore will be excreted because it's really an oxalate absorption problem. The body can regulate calcium on its own for the most part. So, and then you add in, don't restrict calcium, you would restrict oxalate, and you'll obviously, for all kidney stones, hydration is good to dilute those levels. And then in this case, with the calcium oxalate, or like an 8 being like an acidic, like an acidic compound, you'd want to alkalize the urine with potassium citrate um, to kind of counter that out. So, kind of a good thing to know. That's the way I've always thought about like oxalate, with back to your organic chemistry names when you're naming these compounds, 8 representing an organic acid group, you'd want to counter that with alkalization of the urine to solubilize in the acidic compound. So, good way to think of it, and very high yield not to restrict that calcium. So, keep calcium in the gut helps. Continuing on this nice study of stone. So, a patient with chronic diarrhea now in a history of gout presents with severe left flank pain. UA shows many RBCs and a urine pH is actually acidic compared to normal. And they don't see any stone on the CT scan. So, what's your diagnosis, Mike?
This would be a uric acid stone.
Very good. And treatment for a uric acid stone, like I mentioned before?
So this would also involve hydration and alkalinization of the urine.
Absolutely. So take that urine and alkalize it to counter out the acidic stone. And very high yield for the purposes of board exams is that the uric acid stones are radiolucent. So usually, obviously, what's your diagnostic study of choice with kidney stones, Mike, in general?
Typically a non-contrast abdominal CT.
Very good. And there's actually some institutional variability on that. My home institution actually did do contrast CTs because apparently the amount that you'd actually miss with contrast CTs is very low. But in general, on exams, it's always a non-con CT will be the exam of choice to kind of look for stones. But in the case of uric acid, in contrast with like calcium stones, they're radiolucent, so you might not see anything. So keep that in mind. Doesn't mean there's not a stone there. So now let's switch gears. You have a 34-year-old female, history of recurrent UTIs, has fever and flank pain. UA shows RBCs once again, now an alkaline urine pH and crystals that appear shaped like coffins. What's your diagnosis now, Mike?
Yeah, this one has a couple of names. So
Yeah, it does.
AMP, which is what is it, ammonium magnesium phosphate,
Very
uh,
good.
or staghorn caliculi.
Yes, and the other name for that would be the struvite stone. So either struvite or magnesium ammonium phosphate. So what's the pathophysiology? Why do we have this precipitate?
So this
Specifically
is
looking at this
usually
patient,
a
yeah.
co-infection with Proteus mirabilis that will lead to alkalinization of the urine, and then you'll
Perfect.
have precipitation of the struva.
Perfect. So yeah, you're going to have this Proteus species producing a urease enzyme. It's going to alkalize the urine and lead to the precipitation of this magnesium ammonium phosphate. So what would you expect to see on ultrasound if you actually like on exams at least? Not that this is always the case in real life, but what are you looking at for the stone? You already kind of mentioned it.
I'm not totally sure what you're getting at, but I think the size of the stone and the degree of
Correct. Yep.
obstruction.
Yep, that's where I'm going with it exactly. So the large staghorn caliculi in the renal pelvis, basically, a lot of times you'll get an image, whether it's the CT or the ultrasound, you'll see that big stone obstructing basically all of the like from the renal pelvis up into each individual like papillae of the renal like parenchyma, the collecting system, and you'll get that characteristic appearance, the staghorn. So what's your treatment now, knowing that this is a infectious cause of kidney stone?
So you'd want to, first prioritize removing the stone. So usually with like lithotripsy, and then treating with the concomitant infection with appropriate antibiotics.
Yep, absolutely. So just in general, antibiotics, stone removal is very important, obviously. Might not be one that's able to be broken up by lithotripsy, and it's definitely not going to clear on its own. So this might be one where you look and it's so big that it's causing a ton of like backup into the kidneys. This might be one way that they might try to test a percutaneous nephrostomy tube, but usually the stone is like extending up into the point like I don't even know where you put the tube. So really the idea is that you're going to need surgery for this. If you do have recurrent problems, you can give a urease inhibitor to these patients to keep the urine um, within normal limits for pH and not as alkaline because that's kind of your problem. So good to know definitely that these people usually need surgery. So obviously here you go are your different stones. So we'll just kind of rapid fire those off. What would you say those first ones? I would say those first ones all the way on the left, Mike, those kind of look like envelopes. So what kind of crystal are we thinking there?
Those would be our calcium oxalate stones.
Absolutely. So I've always thought about that as having like an X in it as well. So if you don't remember the envelope, remember the X for oxalate. Those second ones there, I would say those kind of represent like maybe a rounded rhomboid type figure. You can kind of see the four-sided shapes kind of mixed in. Which ones would you kind of say those look like?
Those are uric acid stones.
Very nice. So we talked about that, radiolucent. Um, third ones here, you can see those big like rectangles kind of have a little bit of like depth to them, kind of looking like the top of a casket or a coffin lid. So which one would that be?
Those are the struvite stones.
Bingo. And then lastly, we look like a six-sided figure here, hexagonal shapes. What does that make you think of?
That's the cystine stone.
Absolutely. The cysteine or the 16 stone, if you will. So good to know those as just rapid fire. They would be an easy answer for the questions. And they might also kind of do a reverse question where they show you all of this data and then ask you about a pathology that you might be expecting, whether that be, Proteus infection with the struvite stones or Crohn's disease with the oxalate stones, what have you. They'll kind of ask for a reverse way to kind of tie those together. So now we're kind of going into chronic kidney disease, very high yield because it is unfortunately very common. So there's a lot of complications. If you remember from the initial part of the renal review, we talked about just the general functions of the kidney. So now when we see problems with the kidney, chronic kidney disease, a lot of our complications are going to be related to problems with the native function of the kidney. So, first of all, one of the first complications you'll see is anemia due to the lack of erythropoietin or EPO production. So, how do we treat that, Mike?
You can give kind of supplemental EPO.
Absolutely. So, we'll give EPO, artificial EPO. What about a high yield side effect of administering EPO?
One of the more high yield side effects is hypertension.
Yeah. So honestly, I saw this a ton when studying for boards, knowing that this is a cause of hypertension. I think it's kind of high yield because in the setting of chronic kidney disease, obviously you're hoping that they're on an ACE inhibitor to kind of help with the function, or you don't want to see hypertension because that can be a sign of renal failure. But this is actually a side effect of a treatment modality. So that's interesting. You can also get vitamin D deficiency because specifically due to the lack of 1 alpha hydroxylase, since you're going to lose 1 alpha hydroxylase, you will not be able to activate um, 25 hydroxy vitamin D to 125 hydroxy vitamin D. So you have to supplement. But what do you supplement specifically? Actually, very high yield.
You supplement you still supplement 25. Oh, do you supplement 125 in CKD
Yes, you do.
patients?
Yep, specifically calcitriol or 125 hydroxy vitamin D. So this is very high yield because they will make you choose between 25 or 125. The idea behind it is that they cannot activate 25 to 125, so you have to skip that step, bypass it, and give them the activated form of vitamin D. Very high yield to know. And how about this one? They love these questions. What's the most common cause of death in chronic kidney disease?
Like cerebrovascular event. So usually like a cardiac
Yep.
event.
Yeah, so cardiovascular disease, these people are at risk for all the cardiovascular disease, like you mentioned. So, whether it's like acute coronary syndrome or stroke or whatever. Um, so what do you do? What's kind of like your mainstay, along with treating the CKD, with like renal protection and eventually getting into dialysis? But what do you do other than those things?
Start car or protective medications like statin, aspirin.
Yep, absolutely. So really what it comes down to is eventually risk factor modification. So you're going to look, are they at risk for, do they have a greater than 10% risk or 7.5% risk on like the ASCVD calculator? If they do, you're going to probably want them on a statin. Do they need to be on aspirin based on, whatever risk factors they have? You're going to control their blood pressure, you're going to control their diabetes, all of these things to kind of reduce their risk of cardiovascular disease in general. So good to know for sure. So moving on here to probably, if not the, but one of the most high yield chronic kidney disease complications. Specific case here, 70-year-old man with history of CKD stage 3. He presents for evaluation of a painful necrotic skin lesion over his right lower extremity. Labs show no change in his creatinine. He does have hypercalcemia that's increased from previous labs 6 months ago. He also has hyperphosphatemia and hyperkalemia. So what's your diagnosis with this patient, Mike?
This is calciphylaxis because of CKD.
Very nice. Yeah, characteristically very, very exquisitely painful, and that will be emphasized in the question. That is a painful skin lesion. Um, and then what's your pathophysiology behind calciphylaxis? Why does that happen?
This is essentially due to hyperphosphatemia, at least in chronic kidney patients. chronic kidney disease patients. So the phosphate builds up in the blood, which binds with the calcium to deposit in the blood, which essentially causes a vasculitis.
Yeah, very nice. So yeah, mainly driven by the hyperphosphatemia. So if they ask for a true root cause of calciphylaxis in the setting of CKD, they're going for how the hyperphosphatemia will cause binding with the calcium in the blood and the precipitation leading to the calcification overlying necrosis of the skin. So very good, very very good. Kind of moving on here, another complication. You have an ESRD patient and they present with pain in their hips, their arms, and their legs, and you're able to reproduce it on palpation of the bones. So whether that's, palpation of the femur, like midline spinal tenderness, what's this make you think of, Mike?
So this makes me think of uh, is it osteitis fibrosa cystica, which is
Ooh, that
essentially
is,
due to
yep,
hyperparathyroidism.
absolutely. So a couple names for it. It can be called renal osteodystrophy. It can be called osteitis or fibrosa cystica, or secondary hyperparathyroidism. They're all referring to um, the same phenomenon here, which is very important. And one of the classic questions on exams is going to be an arrow question. So I'm going to give these values here. So what would be your expected levels, like just say like high or low, of all of these different measured values? So what about the phosphate in this patient? What would you expect?
Would be high.
Okay, so that's more in the setting of chronic kidney disease. So we'd have high phosphate. What about our calcium level?
Calcium should be low.
Good. So calcium's going to be low, mostly because that phosphate's binding it up. So because you have low calcium, what's our PTH going to be?
That'll be high.
Good. So that's the compensatory. That's the reason it's secondary hyperparathyroidism is because that is going to happen. The PTH is going to be high, secondary to the hypocalcemia. And then what about our vitamin D level?
Vitamin D level should be low.
Good. And that's once again tied to the kidney disease in general, like we just mentioned. Our ability to activate vitamin D is low. So that's just another thing that's going to be driving the hypocalcemia, and the hypocalcemia will be driving the secondary hyperparathyroidism, and that's what's causing this bone breakdown. So that will present with this bone pain, usually in an ESRD patient like on dialysis. Very high yield to keep in mind. How would you treat that? I know it's not on the slide, but like treating the bone pain associated with renal osteodystrophy.
A lot of that would be just managing the phosphate levels.
Yeah, so whether that means you're going to do phosphate binders, like sevelamer, um, yeah, you can also kind of do, I forget what the exact medication is now, just on the spot, but you can treat the hyperparathyroidism, um, like with some of like the calcium mimetics if you had to, but
Are you
really
thinking of
the
like
main.
Sincalcet?
Yeah, that's right. That's right. That's what I was thinking of. Yeah, so you can do that, but the main thing is you're going to decrease your dietary phosphate. You're going to give phosphate binders if you need, like sevelamer, and you're just going to keep treating the chronic kidney disease with dialysis as appropriate. So just in general, just to know what we're talking about when we say dialysis. So what are the different types of dialysis, Mike?
Hemodialysis and peritoneal dialysis.
Very good. So hemodialysis is like your typical, go to the hospital on Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and get your dialysis done, whatever the regimen may be. Peritoneal dialysis is more something that can actually be done at home, um, using the peritoneum as your dialysis membrane. So kind of going into that, like just in general how they work. Not going to quiz you on the mechanism or the mechanics of it. But just in general, so hemodialysis, it pumps the blood through the dialyzer where you're going to have an artificial membrane. Fluid and electrolytes are going to diffuse across that semi-permeable membrane. You're going to remove the waste products. The blood's going to return, basically filtering the blood as the kidneys would, but artificially, extracorporeally, if you will. And then peritoneal dialysis, you're going to use the peritoneum as a dialysis membrane. The abdomen is filled with hyperosmolar solution that draws the fluid and solutes from the peritoneal vasculature, and then the abdomen is drained there. Usually, this is something that can be done at home. One of the very high yield things, if you do peritoneal dialysis, you have technically, like usually you have a peritoneal dialysis port there. So very high risk for like SBP. So if this patient with peritoneal dialysis were to present with abdominal pain, and maybe a little bit of like hypotension, maybe they're fevering, that would definitely be something where you'd want to tap the belly and you do a cell count cytology on it. So just in general now, talking about the emergent indications for dialysis. So what's the old faithful mnemonic here, Mike?
AEIOU. So
Very
A
good.
is acidosis,
Mm-hmm.
and all of these refer to indications after medical therapy is initiated, and these patients have failed medical therapy. So A is acidosis, E is electrolyte disturbance, especially hyperkalemia. I is intoxication, which is essentially medication overdose, especially ones like lithium, warfarin, um, digoxin, aspirin. O is volume overload, and U is uremia.
Very nice. What Mike said is very, very important, especially in real life. Not everybody that has acidosis is going to get dialysis, or else so many people would be getting dialysis. It'd be insane. But these are intractable, or like things where you've tried optimal medical management and you're not getting the results. These are true emergencies. So, like you mentioned, acidosis, intractable, different criteria for this, but really it's that you're not able to solve it with medical management. It's not resolving the way you want. So, if the pH is less than 7.1 or bicarb less than 12, those are just general parameters, like despite medical management, once again. The electrolytes, specifically on for the purposes of exams, if you have persistent hyperkalemia greater than 6.5, that's usually where you're needing electrolytes. Um, and a lot of times where that comes up, obviously, is with CKD. If you were to have hyperkalemia, one of the mainstays of treatment, obviously, you do your insulin and your beta agonist, but really those are temporizing measures. You're moving potassium into the cells. But at the end of the day, you need to get it out of the body. And the way to get it out of the body is either with binders or with loop diuretics. And if you have kidneys that are shot and they're not able to clear that potassium, you're going to need dialysis to kind of get it off. At the end of the day, you just won't be able to get it out of the body if you don't. Intoxications, most high yield that I ran into on the exam is aspirin or salicylate toxicity. And that's specifically because like they love to test that they're going to have like a respiratory alkalosis because they're breathing heavy, like they're hyperventilating because of the stimulation of the respiratory center, plus a metabolic alkal or acidosis because of the effect of aspirin as an uncoupling agent. So that's just a very high yield thing to be aware of in general. And then fluid overload that's refractory, and then uremia based on clinical presentation. And usually that would be whether you have like uremic encephalopathy, pericarditis, or bleeding. So we can kind of talk a little bit about also like the non-emergent indications. This is like the symptoms of uremia. Um, as a bridge to transplant, you can also use it as like a non-emergent thing. So all of those above syndromes are things like, yeah, that's an emergent need for dialysis. Like we need to get that started now. But also if these patients are starting to see symptoms of uremia, you can do dialysis like non-emergently, and then kind of bridge into transplant that way. So anything else to add there, Mike?
Nope, that's all I had to.
Very nice. So yeah, just to know about dialysis, not necessarily they're going to test you on the mechanism or anything, but things to be aware of and when they like to see you use it. So kind of moving into renal transplant, I'm just going to present some information here, not really going to go based on cases because really the things they can ask about with renal transplant are limited because you can really get into the weeds pretty quickly. So just talking about post-transplant therapy, they need immunosuppression to prevent rejection. So usually that's going to present with some combination of tacrolimus, which is a calcineurin inhibitor, mycophenolate mofetil or MMF, and then or prednisone, some combination of them. They'll kind of tell you about what their medication regimen is. They're not going to ask you to guess, but tacrolimus, notably, even though it's supposed to be protecting your renal transplant, is nephrotoxic. So if you were to have a renal transplant patient with AKI, or hypertension for that matter, like I've written there, getting a tacrolimus level is always a good idea, especially in real life. On exam, they might not ask you that, but in real life, almost everybody gets a TAC level just to make sure that everything's in order. And then this is also a good opportunity for them to test side effects of chronic prednisone use. So, bone disease, whether that be avascular necrosis or osteoporosis, infections because you're immunocompromised, adrenal insufficiency if they're withdrawn, things like that. It's all worth thinking about. Just kind of thinking about how they put you in the situation to test these things like chronic prednisone use. This would be a good opportunity. So then you get into the rejection syndrome. So acute rejection occurs within 6 months of transplant. You're gonna have maybe some fever, flank pain, etc., as well as like obviously signs of kidney dysfunction like elevated creatinine and such. The important thing to note here is that if you were to biopsy somebody in acute rejection, you will see lymphocytic infiltrate, very high yield, and the treatment for it is going to be high dose steroids and maybe anti-thymocyte globulin. Um, but yeah, mainstay of treatment is like burst dosing of steroids. So just very super high doses of steroids to try to save those kidneys from the immune response. And then contrast that with chronic rejection now. So greater than 6 months after transplant. Now your biopsy findings are going to be interstitial fibrosis with obliterations of vessels and glomerular sclerosis. So rather than being lymphocyte mediated with like inflammation that way, this is a fibrotic picture, like things just start to fibrose over. And unfortunately, there's no treatment except for trying to replace that graft. So chronic rejection is kind of the irreversible stage of that. And the idea is that hopefully we keep transplants viable for as long as possible before this occurs. So just kind of good to kind of keep in mind both of those. They like to test what you would see on biopsy in those cases, knowing 6 months is your time frame, your biopsy findings, and then for acute rejection, knowing that your burst doses of steroids and maybe anti-thymocyte globulin are pretty high yield. Do you have anything to add there, Mike?
Nope, that was perfect.
Sounds good. So yeah, good scenarios to know about. Not always test that much. So honestly, a very high yield topic that kind of gets glossed over a little bit, and it's in a lot of different shelf exams. Not just internal medicine. You can see it a ton in OB-GYN. You can see it a ton in family medicine because it's very common. It's just not thought of very much. So we'll kind of go through a few cases of incontinence here. So 60-year-old female, she's G5, P5, and she pees when she sneezes. So what do you think, Mike? What's this?
Is this stress incontinence?
Very nice. So stress incontinence, specifically the pathophysiology there being urethral hypermobility due to like pelvic floor laxity is good to know. So because of that being the pathophysiology, what's the initial treatment? What's your best next step? If you know it's stress incontinence, what's the next best step?
Oh man, the next best test for stress incontinence is that the what are those? The Kegel exercises?
Very nice. Often on exams, they're going to be called pelvic floor muscular therapy, or PFMT. Lifestyle changes as well. So just like, whether that be like decreasing fluid intake in certain settings. Pessaries are also kind of the next step up from pelvic floor muscular therapy, and then kind of the last resort, the surgical solution is the mid-urethral sling, where they basically keep that urethra up using surgical reconstruction of the pelvic floor. So that's a very high yield one, very much so associated with older women, often with multiple pregnancies in the history. And then you'll have your urination with increased intra-abdominal pressure, whether that's coughing, sneezing, laughing, all of those things. So now we'll kind of move 70-year-old male, long history of uncontrolled diabetes mellitus. He notices nearly continuous drippage of urine. What's that make you think of, Mike?
Is this overflow incontinence with neurogenic bladder?
Absolutely, it is. So, neurogenic bladder, in the setting of this diabetic patient, you would call it diabetic autonomic neuropathy, but you could see a very much similar presentation with somebody with spinal cord injury, which would be a neurogenic bladder. Same with like some kind of like neurodegenerative diseases can get this as well. So, good to know the nearly continuous drippage of urine. And it is very high yield to know about diabetic autonomic neuropathy. Since diabetes is just so darn common, it's becoming very high yield to be tested. So just having that in the back of your mind at all times is good. So what's our kind of treatment for overflow incontinence?
Is well, I think Tamsulo or alpha one antagonists now have some effect at like the bladder neck,
Yep.
and then the last one is like intermittent calf.
Look at you, man. That's a good job. That's good work. Yeah, so intermittent catheterization is what you would start with in the hospital. If you know you have neurogenic bladder, intermittent catheterization is always preferred on exams to like a chronic indwelling Foley. Obviously, in some cases in real life, a Foley is going to get placed for these patients, but it depends on the situation. So intermittent catheterization versus maybe tamsulosin or finasteride. If you think this is mostly BPH mediated, you can start there. And then, like Mike mentioned, muscarinic agonists like oxybutynin and tolterodine for a hypoactive detrusor muscle. So those muscarinic agonists will increase the contraction of the detrusor muscle and will therefore hopefully cause easier urination and less retention overall. So, like we had kind of mentioned, other than the diabetic autonomic neuropathy, other causes, BPH, spinal cord injury, MS, all these things that could lead to neurogenic bladder or overflow incontinence in general. So, good to know. Kind of moving on to the other causes of incontinence, 65-year-old female, episodes of incontinence and feels like she just can't get to the bathroom soon enough. Specifically, that description. What's that make you think of?
This is urgent incontinence.
Awesome work. Yeah. So urgent incontinence, they'll usually give you that in the exam question that you have an uncontrollable urge or they, feel it and they just can't get to the bathroom soon enough. Um, Pathophysiology behind urgent incontinence, Mike, what's that kind of think of?
So this is the essentially like overactive bladder.
Very good. So in contrast with like we were kind of just talking about um, with the muscarinics agonists, the overactive detrusor muscle will kind of cause the opposite. So now you're going to be peeing too much in unprovoked rather than retaining um, because of decreased contractility. So how do we treat an overactive detrusor muscle?
Relaxing medications.
What ideas do you have for that?
I don't remember.
Yeah. So this is oxybutynin and tolterodine. These are the anti-muscarinics. Those will decrease the action of the detrusor muscle. The other one that's starting to be tested a little bit now is mirabegrin, which is a beta 3 agonist. All of these have the same idea, which we're going to suppress the activity of the detrusor muscle. This is actually kind of a high yield question because, like we've mentioned in other strudel review videos in the past, it's very high yield to be cost conscious. So what if it's not totally clear? What if you're not sure if it's primarily urge? Maybe it looks a little bit like stress incontinence. They give history that's kind of mixed. What's your next step?
I guess you
Very
could get a
conservative.
like a urine ultrasound or like a bladder scan.
Even more simple than that. And this gets tested all the time. Avoiding diary. Just like have them actually track their symptoms. They might come in and say that like, they're having trouble controlling their bladder. But having them do avoiding diary and like document the circumstances which each of these episodes can help you tease out what the dominant mechanism is because there's definitely mixed incontinence that exists and where a lot of these physiologic mechanisms are at play, but getting avoiding diary is a very easy way to try to get a better handle on their symptoms and they like testing that. So keep that in mind. But yes, urodynamic study is also very useful, especially to kind of tease it out if the avoiding diary does not. So now we're kind of moving. How about a high yield case for primary care? So a 50-year-old male presents to the clinic, no past medical history that we know of, but he came in at the request of his wife after his father-in-law passed from a heart attack. He reports an American diet in quotes, couple of Mountain Dew sodas per day. Point of care glucose is 275, blood pressure 155 over 95, and obviously he has this really high random glucose reading, which would qualify him for a new diagnosis of type 2 diabetes. So you're worried about complications of it. So how do we start assessing diabetic nephropathy? What's kind of our test there?
That's I guess you'd start with a spot protein creatinine ratio.
Absolutely. And what's our threshold for saying, this is abnormal, we should do something?
Is it 0.3?
Yep, zero point 0.3 or 30, depending on the units you put it in. So the spot albumin creatinine ratio or spot protein creatinine ratio, looking for a value of 30. What's the pathophysiology behind diabetic nephropathy?
Essentially, it starts with hyperfiltration due to glycosylation of the efferent arterial and afferent arterial, but essentially that causes hyperfiltration, which then progresses to proteinuria and especially like microscopic protein.
Perfect. And what do you see on kidney biopsy? Tough one.
You'd see like mesangial nodules. It's called the Kimmelstein-Wilson
I looked at
nodules, right?
those. Yeah, I just call them KW nodules. You'll have the glomerular hyperfiltration. So because of that, specifically the efferent arteriole with the endothelial damage due to hyperglycosylation, you have the intraglomerular pressure that's increased, so you're going to cause some glomerular sclerosis if it's untreated. So how do we prevent progression? Very, very high yield. So what are one medication and one management strategy?
So I guess ACE inhibitor and then managing A1C and hypertension.
Perfect. So yeah, managing diabetes, and I should have probably mentioned also like managing other comorbidities. So like you mentioned, hypertension. And if you have somebody with diabetes and hypertension, like this patient in this case study, the ideal agent would be an ACE inhibitor and an ARB, or an ACE inhibitor or an ARB, excuse me, to dilate that efferent arteriole to reduce the intraglomerular pressure and therefore decrease the proteinuria. And that's kind of what you would do to check. So that's your renal protection in diabetes. Obviously, you're going to manage the A1C as Mike said as well. So very high yield to know that because they'll make you choose like which medication do you want to use in this newly diagnosed or this diabetic, even if it's been a long time, but that has hypertension now, and you'd reach for a RAS inhibitor. So good stuff there. Very high yield case. So now we're going to kind of do some rapid fire here on the electrolyte disturbances. So kind of put these into the renal category because of how much they kind of play together. But this is really across systems, across shelf exams. It's all over the boards because electrolyte abnormalities can be caused by so many different things. So it's important to identify them and then manage them appropriately. So let's go through this pretty quickly. Very high yield section of the review. So we'll start with a 65-year-old man, history of CHF, presents with confusion, nausea, and malaise, struggles to follow commands during the exam, which is significant for an S3 heart sound, hepatojugular reflux, and bilateral lower extremity edema. His labs show a serum sodium of 118 when the normal is 136 to 144. So what is the etiology of this patient's mental symptoms or like his altered mental status?
Probably is hyponatremia.
Yeah, so in this case, can it be somewhat multifactorial? Probably. I'm going for hyponatremia secondary to CHF exacerbation, which is specifically a hypervolemic hyponatremia. Can there also be some contribution to altered mental status from like decrease, like if the heart is failing, you have decreased perfusion of the brain, and that is something that should probably be thought of as well. But in somebody with a sodium that's this low, usually you're thinking of like a symptomatic hyponatremia. One other thing that's actually been tested quite a bit, um, hyponatremia is a very poor prognostic indicator in the setting of congestive heart failure, because that's just telling you that your fluid overloads to the point where you're kind of diluting and you're unable to catch up. So you're hyponatremic because of that. So that has been tested for me before. So keep that in mind. So what's our like common clinical features of hyponatremia, not off of hyponatremia, but these are neurologic symptoms for the most part. So headache, weakness, delirium. You can have increased ICP and leading to seizures. You can have nausea, vomiting, ileus. I would say the most common is going to be like altered mental status, maybe like a hyponatremic seizure. Um, but really, it's going to be like identifying the history consistent with something that could cause hyponatremia is very important. So additional labs for hyponatremia, um, what kind of studies would you do in somebody in the workup for hyponatremia?
Um,
Yeah, very nice. So this is just additional labs. Um, Not necessarily we have like a better slide coming up here for the approach to hyponatremia, but in this patient specifically, we'd want to get some urine studies for urine osmolality, urine sodium. These should both be low. They should be low in the setting of hyponatremia, because if the kidneys are functioning correctly, if you have low sodium, they're supposed to be retaining it. You shouldn't be losing it in the urine. So that would identify a different problem. But we'll kind of go through the approach in the next slide. But what's very high yield, so this patient we've already established has symptomatic hyponatremia to 118. So what's the management for this patient? How should we treat this patient?
so for this patient, probably diuresis if they're hypervolemic. But typically, some other things we could do is normal saline, salt tablets, or hypertonic saline. I think for this patient, the answer is probably going to be hypertonic saline because of his neurologic symptoms.
Very
But on the boards,
Yeah, so kind of like Mike said, there's a lot of things you could do. But specifically, the board answer here If you have severe hyponatremia, like less than 110, which is really low, I've never seen it that low before, or if they're symptomatic from their hyponatremia and it's kind of getting near 110, it's still above that though, like this patient 118, you could make an argument for hypertonic saline in those patients. But for the large majority, if they're not symptomatic or their glucose or their glucose, their sodium is greater than 110, just normal saline is very high yield. And just a little in general exam taking tip, if they offer an option, an answer option that's either normal saline, LR, or just generic crystalloid solution, it's often the correct answer. It's a very good place to start in management with a lot of these things. So just to keep that in mind. But if they are symptomatic or they are less than 110, the exam usually wants you to pick 3% or hypertonic saline. And if they're not symptomatic, they're greater than 110, you would just do regular, everyday, normal saline. So let's say you decide to do hypertonic saline. What's the textbook complication of hypertonic saline, trying to raise the sodium level?
Osmotic demyelination syndrome.
Perfect. So a couple different names for it that it could go by. So central pontine demyelination or osmotic myelinolysis. Basically, the tip to know here in real life is that you do not want to correct the serum sodium any faster than 4 to 6 milliequivalents per liter in the first 6 hours, and I believe it's somewhere between 10 to 12 milliequivalents in like the first 24 hours. And if you were to kind of be correcting it that fast, you would actually stop the hypertonic saline and give some normal saline to prevent the sodium from rising that fast. So the old mnemonic is from low to high, the pawns will die in this case. So if you go from low sodium to high sodium too fast, you'll get pontine demyelination. So very high yield to know that case. So here's what I was talking about. The first step in the approach to hyponatremia is measuring the serum osmolality. So this is a specific test. There is a calculated serum osm that comes with most chemistries, like in an EMR, you'll see that lab value, but you would want to order a specific, like a specific individual serum osmolality to determine if this is hypertonic or a true um, hyponatremia or a pseudo hyponatremia, as Mike mentioned, with protein or triglycerides. So in general, what you should look for, what you're expecting, is true hyponatremia, which is a hypoosmolar hyponatremia. So let's say that's what you get. You have a true hyponatremia. So what's your next step in evaluation of this patient?
Assessing the volume status.
Yep, perfect. And this is something that is really important to get good at and to realize, what you can do to assess volume status in real life, because it's a very common thing that we're looking at in the hospital. So you'd assess the volume status, you'd see if they're hypovolemic, euvolemic, hypervolemic. So let's kind of go through the differentials for each of those. So let's say you have somebody, they are hyponatremic, they are truly hyponatremic, which means that they are hypoosmolar as well, and they are also hypovolemic, or they're dry on exam, dry mucous membranes, no edema to be seen. What's your next step in evaluating hypovolemic hyponatremia?
So if they're hypovolemic and they're hyponatremic, then you probably want to obtain some urine studies and see if the kidney has appropriate response.
Perfect. So yeah, you're going to measure that urine sodium. It should be low. In the case of somebody who's hyponatremic, the kidney should be working as hard as hard as it can to reabsorb all that sodium that it can. So it shouldn't be losing any in the urine. If it is, then that usually means that something's happening, something's affecting the kidney's ability to retain sodium. On exams, things to think about would be excessive diuretics. So, a textbook question there would be somebody that's kind of obsessed with their body image, whether that be like anorexia or bulimia, and they are taking excessive diuretics. They'll usually give you some lab values to kind of back that up. Like they'll be like hypokalemic as well, but that's something to think about, would alter the kidney's ability to retain sodium. And then low or hypoaldosteronism, which can be caused by a lot of different things, but just in general, hypoaldosteronism. So now you have hyponatremia and they're euvolemic on exam. What's your differential and how would you kind of differentiate the two? What test would you do to differentiate them?
To differentiate between the causes of euvolemic hyponatremia, you mean?
Correct. Yeah. So what are the two causes, the main causes of euvolemic hyponatremia, and then how would you differentiate?
So SIADH is one of them.
Perfect.
Um, that's the main one I can think of. Otherwise,
The other one is going to be psychogenic or primary
oh,
polydipsia.
that's right.
So that's usually associated with like psychiatric disorders where they're going to be drinking like a crazy amount of water. And SIADH, like we mentioned, is very much associated with like intracranial pathologies, old age, and like SSRIs are associated. There's a lot of ways they can test SIADH. Ectopic ADH um, from like neoplasms can cause this. But the differentiation is going to be done with the water deprivation test first. And that's a very high yield exam point because, once again, easy test to do. You just don't let them drink and you see what happens. In psychogenic polydipsia, taking away the water will result in a an improvement in the hyponatremia pretty quickly because the kidneys are completely fine. There's nothing telling the kidney to resorb or don't absorb water, but you're just overwhelming the kidneys with excess free water intake. Whereas with SIADH, it doesn't matter how much fluid you're taking in. You have ADH going all the time. So if you have ADH all the time, as you guys know, ADH works in the collecting duct, increases the expression of aquaporins, you're going to resorb excess water constantly, regardless of what you do with your fluid status. So in that case, take away water and there's no change, that would be suggestive of SIADH. So let's talk about the next kind of differential here, the hypervolemic hyponatremia. So we already kind of mentioned this in the last case, so I'll just kind of reveal that. So the three main pathologies to be thinking of would be CHF, congestive heart failure, nephrotic syndrome due to loss of protein, and like edema that way, and then liver disease with fluid overload secondary to liver disease. So knowing that those three are the kind of main etiologies are very important to know. So kind of moving on, more electrolyte disturbances here. So now we have a 25-year-old female, history of bipolar disorder, well controlled on lithium, presents for routine evaluation. Her vitals are normal. Her physical exams largely unremarkable. Her labs are significant for a sodium of 150. No change in her diet or fluid intake is reported. So what are you thinking as far as an etiology for hypernatremia in this patient?
So, is this the nephrogenic diabetes insipidus?
Perfect. So yeah, so nephrogenic diabetes insipidus, specifically secondary to lithium use in this patient. So with NDI, this is in opposition with ADH or with SIADH, excuse me. Diabetes insipidus is resistance to ADH, or lack of production. Specifically, nephrogenic DI is ADH resistance. The kidney is not responding to ADH like it should be. So what additional labs would we want to look at in somebody with NDI?
So the additional labs would be,
Yeah, so it's kind of a tough one. Really, what you're going to want to do is you're going to want to look at the urine. So first of all, look at how much urine they're making. In the case of if in the case of hypernatremia, you should have low urine volume. Your ADH should be ramped up, and you should be resorbing a ton of free water to try to dilute that sodium. If your urine volume is high, that means that there's a lot of sodium being excreted and it's pulling water with it. So the way I think about diabetes insipidus is that you are going to have large volumes of inappropriately dilute urine. So just kind of take a minute and kind of think about that. You're going to have large volumes of inappropriately dilute urine. So you're going to have this dilute urine when you should be concentrating the crap out of your urine so that you can resorb as much free water as possible to fix that hypernatremia, but you're just not able to do it. So it's inappropriate dilute urine. So, like I said, your urine osmolality in this case with hypernatremia should be somewhere greater than 800, um, as the body is not responding to ADH telling it to reabsorb water. So the urine should be greater than 800, and in this case, it'll be less than 800, or usually like less than 200, I believe, will be inappropriately dilute because of the ADH not responding to ADH. So what's your treatment for this patient specifically? So she has nephrogenic diabetes insipidus secondary to lithium use. What's your treatment? Okay, so that's definitely something you can try. Usually on exams, you're not going to want to hold the lithium in a patient with bipolar disorder. for the risk of like manic episodes and stuff like that, because that can be dangerous as well. So yes, in real life, could you consider like weaning off of lithium, switching to something like valproate? Sure. But for the purposes of exams, the treatment's going to be a milleride, which is one of those potassium-sparing diuretics that works farther down in the collecting duct on those ENaC channels. Notably, if you have NDI from another cause, whatever that is, thiazides are the treatment of choice for nephrogenic diabetes insipidus. But because of thiazide's interaction with lithium, it would actually make it worse. So this would be one of the rare scenarios where milleride is going to be the treatment. And on exams, this is pretty high yield. So talking about diabetes insipidus, how can central versus nephrogenic diabetes insipidus be distinguished? So how would you compare the two? What would you do, Mike? What kind of test?
This is a desmopressin one, right?
There you go. So
There'll
to
be a
be
lot of editing in this videotape.
so the desmopressin trial, what you would be looking at in a case of central diabetes insipidus, otherwise known as ADH deficiency, you're not making ADH for whatever reason. A desmopressin's trial would completely fix the issue. You'd provide the ADH that you needed, so you would expect the urine osmolality to correct with a dose of desmopressin. In a case of nephrogenic DI, like this patient, we're not responding to ADH, and you wouldn't respond to desmopressin either. So you would have no change in the urine osmolality. It would stay inappropriately dilute despite the attempt of desmopressin to try to concentrate it and act like ADH and resorb the water. You wouldn't be able to do it because the kidneys aren't responding. So, in review, the central diabetes insipidus would respond well to a desmopressin trial. The urine osmolality would correct, in contrast with nephrogenic DI, which it would have no effect. So good to know there. So now we're kind of moving into hypernatremia. Sorry. So just to kind of rapid fire this one, a lot less, I would say a little bit um, less high yield than hyponatremia. So first step in evaluation of hypernatremia largely comes down to volume status, because if you have hypovolemic hypernatremia, these are things that we see actually kind of quite commonly. And this is dehydration. This is where your water loss or your available or your ability to replace water um, is just like is limited. So this is like inappropriate diuretic use, or just diuretic use in general can get, if you're dry enough, can get hypernatremic. Renal failure, in certain cases, diarrhea, sweating, basically all these cases where you're going to be um, losing fluid. So treatment for this is really to restore euvolemia. So let's say you had somebody, you think that they're hypernatremic because they've had severe diarrhea the recent days. So Mike, what would your treatment be? Your first treatment?
I would give them some fluids, some like normal
Bingo.
saline.
Yeah, just like we mentioned earlier, crystalloid is not a bad answer. It's never a bad answer. Specifically, if they're hypernatremic, you could do either isotonic saline, like NS, or you could do LR as well. So now let's say, if you're euvolemic, kind of like our last patient was euvolemic on exam and she was hypernatremic, that's when you start thinking of you're losing free water um, inappropriately. You have that and that's basically the picture of diabetes insipidus if they're euvolemic. And treatment for that, like we had mentioned, if it's central, you're going to get benefit from vasopressin. If it's nephrogenic, that's when you start kind of vasopressin, like we mentioned, wouldn't work. So that's when you start doing like low sodium diet, a thiazide or a milleride in the case of lithium toxicity, and oral fluids to kind of start working on that problem. So then just kind of talking about hypervolemic hypernatremia. When would you see hypervolemic hypernatremia? Sorry. When would you see this, Mike? It's kind of a really weird um, differential.
You'll have to give me a hint. I honestly don't even really remember.
Yeah, so really a lot of this is going to come down to syndromes and where you're gonna retain a lot of sodium due to the activity of mineralocorticoids. So what does that make you
Oh
think?
yeah, this is like primary hyperaldosteronism, right?
Bingo. So primary hyperaldosteronism or Cushing syndrome, as if you have too much cortisol, you could end up stimulating the mineralocorticoid receptor. Um, but most likely like primary hyperaldosteronism or like Conn syndrome when it comes down to like an adrenal adenoma producing that, or like other causes of aldosteronism as well. So treatment. of all of these conditions you have of these hypervolemic hypernatremia is really going to come down to, okay, how do we get rid of fluid and salt at the same time? How do we do that, Mike, in the hospital?
Uh, Diuresis. Would
Diuresis, absolutely. So put them on a loop diuretic, correct the volume, and get rid of some sodium at the same time. You can also do D5, which for the sake of like calculating all these electrolyte things, D5W is just free water. The sodium or the dextrose in it is there, but really like the way to think about it is like you're just giving free water to kind of dilute that. But what if you are doing that and you lower it too quickly? Now what are you worried about?
cerebral edema.
Bingo. So in the same way we said from low to high the pawns will die and from high to low the brain will blow, and that's cerebral edema. Notably, one of the things that I've kind of seen creeping up a little bit more, and people like to ask about it because it's the same physiology, is this can happen with any osmolyte or any like osmotically active substance being lowered too quickly. So one of the most popular situations I've seen this tested is somebody like a kid in DKA. So like initial presentation of type 1 diabetes and their glucose is super high and they're super insulin sensitive and you give them insulin and you drop their sugar too fast, like it just bottoms out too quickly. That can also cause cerebral edema, which can be very dangerous. So just something to keep in mind. It can happen not just with sodium, but with other things as well. So now this is kind of the last portion of the renal slides here. Specific electrolytes, not sodium. Sodium has a pretty complicated workup to it, but really this is we're going to contrast high and low levels of these electrolytes and kind of what they look like on exam. So causes of hyperkalemia, just kind of give me a few of them, Mike. Rattle them off.
Kidney disease.
Sure.
Like iatrogenic from
Yep.
corticoids, and
A lot of
then in that same
medications.
vein, yeah, in that same vein, medication.
Absolutely.
Um,
Couple other important ones to note, like tumor lysis syndrome, rhabdomyolysis, like you mentioned, like hemolysis, like for any cause, and then iatrogenic being ACE-ARB, spironolactone. You can get hypoaldosteronism where this would happen. Um, Presentation of hyperkalemia, largely nonspecific, um, as far as like clinical signs, usually like weakness, hyporeflexia, and arrhythmias being the important thing. So what would you see on the EKG of hyperkalemia? Very, very high yield.
these would be the peak T waves,
Okay. And then what if it got
and then
worse?
you can get the sinus
Yep.
EKG,
Absolutely.
or
So
the sine wave.
yep, there you go. So you'd have your peak T waves that can progress into like widening of the QRS, and then the bad thing is if you start seeing sine wave morphology of the QRS complexes. So treatment, what's your first step if they have hyperkalemia and you see EKG findings?
Cardiac membrane stabilization with calcium, gluconate, usually through the IV, and then then your management of choice for hyperkalemia, usually like either insulin with D5W or albuterol, and it would give like a long act, like a uh, potassium binder too.
Perfect. Yeah. So first step is going to be calcium gluconate. That's the right answer on the test. Then your different therapies that are going to work on lowering the potassium. So, like I mentioned before, insulin and dextrose, insulin's going to move potassium into the cells, as is beta agonists such as albuterol. But those are temporizing measures. You need to get rid of the potassium. So you do that with a loop diuretic, a potassium binder, so you get it out in the stool, like K-exalate, for example. And then, like we had mentioned before, if it's refractory, that's when you go to dialysis. So now looking at hypokalemia, causes once again very very wide range of causes. Most common on exams, um, loop and thiazide diuretics because they're just so common. Vomiting and diarrhea cause a hypokalemia, specifically a hyperchloremic hypokalemic metabolic alkalosis. And then one that comes up on exams all the time, I know I have those ones about laxative and hyperaldosteronism, but having low magnesium makes it very hard to um, replete potassium, and that's tied to the kind of the mechanism involving like ROM-K channels in the kidneys. So there's kind of like this idea that if you don't have adequate magnesium, you're not going to absorb or reabsorb potassium as well, so you'll lead to a hypokalemic state. Presentation of hypokalemia is much the same. Arrhythmias, weakness, and hyporeflexia looks almost the same as hyperkalemia. But in this case, there's also this kind of mix in with like constipation or ileus. This is something that comes up on the surgery shelf quite a bit, because I believe it's kind of associated with like Ogilvie syndrome, um, and like pseudo obstruction or ileus in like post-operative states. Something to check would be their potassium level. So, Mike, what would your EKG findings with hypokalemia be?
These would be like the U-shaped uh, T wave.
Very good. So yeah, so you get the T wave flattening followed by the finding of U waves, which are just those like it's kind of like a secondary wave after the T wave, which is pretty like low amplitude, pretty flat. So treatment for hypokalemia really is going to come down to how do we replete it. So there's a couple ways to do it, and then you can either do oral KCl, or IV at 10 milliequivalents an hour. I believe you can go up to 20 milliequivalents an hour if you have like central access. Is that right, Mike? Like in acute
Yeah,
settings to
that's right.
treat it? Yeah, so 10 milliequivalents through the peripheral IV, and then 20 if you had a central line in. But really, especially on the case of exams, stop the med. So if they're hypokalemic and they're on a loop diuretic at home, that would be your fix. If they're on a ton of laxatives or they're someone that's taking like laxatives in the attempt to lose weight, then that would be an indication to stop the laxatives and replace the potassium as well. So just keep that all in mind. So moving on to magnesium now, also very high yield. So hypermagnesemia, um, what are some of the causes of hypermagnesemia, Mike?
Usually supplement either excessive supplementation or giving it through the IV,
Perfect.
like excessive repletion.
Yeah, so I like looking it up. Renal disease and rhabdo are both are causes that can happen, but for the large majority of cases, especially on exams, it's going to be iatrogenic. So they're going to have increased intake, whether they're in pregnancy, they have eclampsia, and you're going to give them mag sulfate, and you let that thing run, and they get hypermagnesiemic. Arrhythmias, you can like where you give magnesium to fix the arrhythmia and then you get hypermagnesemia like we mentioned before, and then like magnesium based laxatives can also kind of cause that if you have enough of them. So what's your presentation of hypermagnesemia, Mike?
So usually this will be a person who's more sleepy and then maybe has slowed reflexes and then eventually has some respiratory depression.
Very nice. So, absent deep tendon reflexes, respiratory depression, and in general, just like sedation, like you mentioned, these people get really sleepy. So just keeping that in mind if you see those things, and then management of hypermagnesemia now, Mike, what do you go for?
Usually management is like supportive until the magnesium is clear.
Yeah, so one option, obviously, if they're on a mag infusion, let's like stop that. That's a good idea. But also the treatment for hypermagnesemia that's causing like really severe respiratory depression would be a calcium salt, like either calcium gluconate or calcium citrate, as well as this would be another indication for dialysis if it were emergent. So now kind of moving into hypomagnesemia. Causes there malnutrition. You can see this a lot with like alcoholics. Loop diuretics cause hypomagnesemia, malabsorption of magnesium with like, inflammation in the colon, stuff like that. Refeeding syndrome can cause hypomagnesemia. Presentation of hypomagnesemia. What would you see? What's the arrhythmia we're most worried about, Mike?
This would be like torsades.
Yeah, so what you'll see with hypomagnesemia is a prolonged QT, and that can eventually lead into torsades, which is kind of your fluctuating arrhythmia. Check out our cardiac review. We have an image of torsades on there and the management for that. But if you have hypomagnesemia and you're aware of that, management for it is really going to be repleting it and then placing them on telemetry because we're scared of the prolonged QT and the torsades, which can cause cardiac arrest. So, and also, if they ask like what test would you want to get, an EKG would not be a bad idea in this case, as well, just because of the risk of arrhythmias to kind of check on the QT. But in real life, put them on telemetry. We'll replete their magnesium, um, and we'll go from there. So calcium now, moving into this, very also high yield because it has characteristics exam findings specifically for hypocalcemia. So causes of hypocalcemia, once again, a lot of them, but we kind of talked about some of them. So vitamin D deficiency and hyperphosphatemia both can be seen with like CKD, like we've talked about in this lecture. Hypoparathyroidism with decreased PTH. Loop diuretics can also cause calcium wasting. Post-thyroidectomy is actually a pretty high yield syndrome. They'll go in for like a, either a thyroid lobectomy or like a total thyroidectomy, and you'll also kind of like damage the parathyroid tissue, and you'll have hypocalcemia secondary to hypoparathyroidism in that context. But what about probably the most high yield thing to identify it? What are the characteristic exam features or signs that you see in hypocalcemia, Mike? And how would you describe them?
So this is I don't know how to pronounce them, but it's like
Yeah,
the Svastek sign, which is the facial spasm with tapping of the face, and then the Trousseau sign, which is like basically like a spasm of the muscles of the arm, especially with like a blood when take like a blood pressure or like upon tapping of the.
perfect. Yeah. So Trousseau's sign being the like they'll call it carpopedal spasm. Chvostek's sign if you tap on the facial nerve. But in general, tetany, you can get hypocalcemic seizures. A prolonged QTC is characteristic of hypocalcemia if they asked you for an EKG finding. Management is going to be repletion with IV calcium and really treating the underlying cause. So if they're hypoparathyroid, you're going to have to kind of like manage that. If they're vitamin D deficient, we're going to supplement vitamin D. If they're malabsorptive disease, like Crohn's or something like that, and you have fat malabsorption, you like lose the A, D, E, and K, then you would want to treat that inflammatory bowel disease to fix it. Um, all these things, it's really just going to be targeted at the underlying cause, but otherwise you'd replete it with IV calcium. Um, and then how about hypercalcemia now? Like hypercalcemia can be due to hyperparathyroidism, either primary or even tertiary. Familial hypocalci or hypercalciuric hyper or hypocalciuremic hypercalcemia. Sorry about that. It's a tough one. Malignancy, hypercalcemia malignancy with like increased PTHRP. We mentioned this in one of our other videos, like pulmonary video, I believe. Granulomatous disease via 1-alpha hydroxylase from the epithelioid macrophages in those cases. Multiple myeloma, all those things that you see underlined there, very high yield causes where they'll set you up to say, okay, they're hypercalcemic. What's our like mnemonic for the presentation of hypercalcemia, Mike?
I don't actually know what. Oh, is I don't know what mnemonic you're referring to actually.
Oh, so this is like
Uh,
the stones, bones, groans, psychiatric
oh,
overtone.
that's right.
Yeah, so stones being kidney stones, bones being bone pain, groans being like a constipation, and then like psychic or psychiatric overtones being well, usually like it's tested as like maybe a little bit of anxiety, depression, stuff like that. So let's say you have somebody and they're symptomatic. They have symptomatic hypercalcemia, very high yield. What's first line treatment, Mike?
That would be like IV fluids generally.
Bingo. So IV fluids if they're symptomatic. Other things to kind of consider if they have bone lesions, um, for whatever condition, for whatever the case is, bisphosphonates are usually an idea for that to decrease the breakdown of bone, therefore decrease the amount of potassium that's going to be released. Maybe calcitonin. I've never answered that as a question, but it's just worth considering because calcitonin in general um, decreases calcium levels. So good to know. It tones calcium levels down, if you will. So, kind of moving into a couple miscellaneous cases just to end it off, things that are just very high yield that don't really fit in any category that we went over. So, a 14-year-old boy has scrotal pain. An exam shows an irregular mass above the testicle that enlarges with Valsalva maneuver and reduces when supine. What's this, Mike?
There's a varicocele.
Perfect. So, very high yield. So, this is like that bag of worms that can be described, but they're never going to give you that on exam. It's usually going to be like an irregular mass. What's your next step? How do you go about diagnosing?
This would be a testicular ultrasound.
Perfect. And then what's the most common side that's affected?
I always get this one mixed up. I think it's the typically affects the left side.
Correct. So the
Is it
most
the right
common
side?
side affected, is a left-sided varicocele. You have like let's say an older patient, not a teen, but an older patient with a left-sided varicocele. What do you think of, Mike?
That would be like renal cell.
Yeah, so a very high yield case here. So renal cell carcinoma, and specifically it's because there's a 90-degree angle, 90%, 90 degree is what that's supposed to be, angle of entry between the left gonadal vein and the left renal vein. And because of that, an obstruction can easily cause backup down that vein. So if you have that, that'd be a good reason to get a renal ultrasound as well, especially in the right patient. So with renal cell, they'll give you smoker, recent weight loss, all that stuff, maybe some hematuria as well. So treatment for a varicocele is really going to be surrounded by like how do you get rid of it, and why are we worried about varicoceles? What do they cause? Especially a 14-year-old boy. Why do we want to manage this, Mike?
They can cause infertility, but usually it's reversible.
And so, like we mentioned, the risk if untreated is infertility because of that increased temperature, because you just have like more blood hanging out down there than normal. And then I believe this is the final slide here, the renal review. Another miscellaneous case. So a patient presenting with signs and symptoms of kidney stones, and they're found to have hexagonal crystals in the urine. We've already mentioned this on one of our past slides. So what is this, Mike, with hexagonal stones?
This is the cysteine stone.
Yeah, so you have cystinuria. So notably, this is a genetic disorder, and there's a classic test that's done, and they'll give it to you. They'll say that there's a positive this test. And if you see it, you have to know that this is cystinuria. It's all the time that I feel like it gets tested more than it should. So what is this test? Can you bring it from the back of your mind, Mike? So this is a cyanide nitroprusside test. So if you see that, they're telling you it's cystinuria. And for step one specifically, they like you to know what the pathophysiology behind cystinuria is, Mike. Do you remember this one? Yeah, you might see this on a PEDS shelf. You might see this definitely on step one. So this is where you have deficiency of that CoLA transporter, which decreases the reabsorption of cysteine, spelled wrong there, ornithine, lysine, and arginine from the tubule. So you'll have deficiency of all of those um, amino acids because you can't resorb them, but you'll also have increased amounts of those in the urine, and cysteine will precipitate. So treatment for these patients is going to be hydration and alkalinization of the urine. Usually that's pretty good practice in general. If you have somebody with kidney stones, conservative management is going to be to hydrate, alkalize the urine, and then treat an underlying cause, whether it's obviously there's nothing you can really do about the genetics, but in the case of like the oxalate with Crohn's disease, if there's uric acid, there are things you can do to lower those levels. So that's all we got for renal disease. We appreciate you guys tuning in. Mike, do you have anything to add in general? Just study tips about renal in general. I think it's an interesting one because it crosses off or crosses over with so many different systems, and you'll see it on basically any shelf can test renal physiology. I think you only got like two wrong or something. So
Oh, that's okay. On the recording, I'll get zero wrong because I'll edit them all out.
that's what I'm talking about.